So this is my topic, and there are a lot of various risk factors why the lens is subluxate: trauma, previous ocular surgery, special retinal surgery, intravitreal injections. They cause Marfan's, homocystinuria, pseudoexfoliation. These are the various causes due to which we find subluxated lenses. And there may be progressive and or generalized weak zonules in these cases. The management of the subluxated lenses, there is some overlap between KP's slides and my slides, but I'll try to make it as brief as possible. So the most important thing is that when a patient of subluxation comes to you, you have to plan a strategy which is divided into investigations, the preoperative precautions that you take, the intraoperative measures that you take, and the postoperative monitoring of a patient. Now, investigations, it is very, very important, and it is not only for a subluxated cataract patient, but every patient whom you plan to do cataract surgery should be dilated and a slit lamp examination should be done. The rule of the thumb is that when you do a slit lamp examination, you will see the subluxation, you will see whether there is vitreous in the anterior chamber.
What I'm just saying is, in case he's got
and the rule is that whatever subluxation you see on the slit lamp will be much less than what you see on the table. So you have to be prepared for that.
Yeah.
If there is a possibility that you can get a UBM done, it is important because you can, by UBM, assess the relation of the ocular structures to each other and whether there is any more damage occurring. B-scan and retina examination is a must. These are also important for medico-legal purposes, because if the patient has had history of trauma, then the retina examination is very important, because you may miss out something in the retina which may be a cause of poor post-operative vision. So this completes the gamut of a complete workup and measurement of intraocular pressure, because the patients who had trauma or associated disease can be having glaucoma, could be having glaucoma, so that should be taken care of. So these things are very, very important. Preoperative precautions is counseling of a patient. It's extremely important, because you have to sit the patient down and tell the patient that this is not a straightforward surgery like any other cataract. This is complicated. The surgery might take a longer time, because if the patient is watching on TV, he might say that the previous patient got operated in so and so time and these things were not taken care of, or some different techniques are being performed. The need for a vitrectomy. So a vitrectomy standby anyway should be available for all cataracts, but you have to ensure that definitely and 100% it is there for the subluxate lens. And the post-operative possibility of a retinal detachment and the cystoid macular edema, vitreous loss are real, and they should be kept in mind. So even though the patient may have good post-operative visual recovery, what happens a few months later has to be watched, and the patient has to be warned about it. So intraoperative, what are the measures that you will take? So this is the algorithm for the intraoperative, which Krishna Prasad has already described, that how your management takes place depends on the amount of subluxation. If the subluxation is very, very small and it does not hamper with your surgery, you can go ahead with a very careful surgery. If it is about say superior or inferior, you can do with a CTR with an IOL implantation. If it is a larger, then you can use more devices. And if it is so large that you may have to do an intracapsular surgery, or you may have to go for a secondary IOL implantation and an iris fixated lens, the merits of which can be decided by you. Any technique that works in your hand but which is the best for the patient is the most important thing in your life. When you start the surgery, you have to plan the incision. So how do you plan the incision? Like if you're doing a phacoemulsification, you have to plan it in such a way that it is diagonally opposite the site of the zonular dialysis, so that there is very little or the least stress on the maneuvering that you are doing. So that is extremely important, and he should not, but at the same time, surgery should not be done in an uncomfortable position, just so all that is very, very important. The incision itself will cause some amount of refractive errors, and that also has to be kept in mind. So all these things are very, very important. the amount of viscoelastic, and viscoelastic plays a very, very important role because it protects the corneal endothelium. Your maneuvering, and the time taken for surgery is going to be more than a routine phacoemulsification. Protecting the cornea, which is like God, and the endothelium, which cannot be replaced, is very, very important. And also a good viscoelastic will prevent the subluxation or will put pressure on the vitreous from prolapsing further. Capsular rexes should be away from the area. It should be started in an area away from the dialysis. The trypan blue dye is very, very helpful because it stains the capsule and it makes your life much easier. And it should be centered on the crystalline lens and not on the pupil or the corneal apex. So the lens is, it's decentered, but one must remember that the rexes should be centered on the lens and not in the center of the pupil. So as you can see over here, the lens is decentered. You can see a white cataract with a trypan blue stained capsule, and you can see the orange glow, and that shows a large area of subluxation. As you can see over here, the rexes appears to be decentered, but actually you are centering it on in the center of the lens, because later on you will be trying to use devices to inflate the bag and make it central so that your rexes become central too. So this is extremely important. You can use the needle or the Utrata's forceps or specific forceps to do this. Hydrodissection or hydromaneuvers should be very, very, very careful, because you will be increasing, by increasing the amount of fluid in the bag, you will be increasing the volume, the weight of the bag, which can cause a pressure on the zonules, or which can cause more subluxation or dislocation. So small amount of fluids, multiple points of hydro, if at all no hydro, but very little hydro, very, very careful hydro, because otherwise we'll be creating trouble. The lens orientation, the placement of the lens is very, very important, because you have a lens which has a 12.5 millimeter diameter, and the loops itself, act to inflate the bag and to stretch the bag. So if it is an SICS or a 3-piece lens, you can use these loops to your advantage to stretch the bag itself, which is going to be so important. So orienting the IOL is very, very important. There are two schools of thought, and whichever suits you the best, but I always find that it is an advantage to use the haptic to stretch the bag. Capsular tension rings have been described so much in detail by KPs, and they have changed the way that subluxator lenses are being, cataracts are being treated. He has already described the various sizes, open and closed loops. Now, when do you insert and how do you insert it? So they are simply inserted with the use of forceps. They have these eyelets which can be used with a Sinskey hook, and they can be inserted very well. So as you can see over here, this is the Ctr ring which is being used, and you can see that it is under the capsule, and it is being put inside the eye, as you can see over here. So this is how you can place the Ctr ring before or after the removal of the lens, or before the implantation of the cortex. So contraindications are if there is a PC tear, or if you don't have a CCC, or if there is zonular weakness. So this is the case that I'm going to show of phacoemulsification in a subluxated lens. As you can see that the rexis is being made over here. And you can see the traumatic cataract, because you can see the rosette, which is very, very visible over here. And the rexis, which is in the center of the lens, as you can see. And the gentle hydro, you can see the golden ring, but small amount of fluids, and a gentle hydro is being done. As you can see over here, this is a very soft lens, and you can see the subluxation.
Ragini, you can continue. Time hai. You can continue.
So, Mehta sir, can I continue?
Please ignore it. Just keep going.
Yes, sir.
You can
So
continue. Time hai.
as you can see over here, that this is a soft cataract, and you can now, it is slightly, the nucleus is slightly made free, so as to not make or give any pressure on the lens itself. And then now you know, sometimes you don't want to do iris plane phaco, but not to give pressure on the bag. You can do it by using a good viscoelastic to protect the endothelium. And this is a very soft cataract, and you may not use to divide. You can just use more aspiration, but as you can see over here, you can see the subluxated, but the lens is out of the bag. It is on the iris plane, and only the aspiration or vacuum is used. Luckily, this was a soft cataract in a young patient, and you can see the folded capsule over there. In this case, it was decided to use the capsular tension ring after the phacoemulsification was complete. And as you can see over here, the capsular bag is being stretched by the use of this Ctr ring, and then you can see the folded capsule opening up, the bag stretching, and the area of subluxation visibility getting smaller and smaller. I'm really sorry for really overshooting my time. And this is the placement of the ring.
Please take your time.
वो जा रही बोल रही मम्मी वो.
And as you can see over here, the Ctr ring has been put inside, and you have to be very careful while removing the cortex, because otherwise the Ctr ring gets pulled, as you can see. So very gentle teasing movements ensure a complete cortical cleanup. And then this is the insertion of the intraocular lens. Which can be put inside the bag because the bag is inflated. There is availability of the space for you to put in the bag. One must remember here that if necessary, if there was vitreous, this surgery can be completed only by a complete vitrectomy, because as Jaffe has said, that it is the vitreous where it should not be, causes all the problems. So vitrectomy is a part of the procedure. Mehta sir, I once again apologize for taking this extra minute, which was not fair at all, but I'm extremely sorry for that.
Not at all. We have ample